Next speaker is Dr. Makeda Semret, who is an associate professor in the Department of Medicine, Division of Infectious Diseases at McGill University, and a medical microbiologist based at the McGill University Health Center, or MUHC. She leads the Antimicrobial Stewardship program at the MUHC and is a co-director of McGill's Antimicrobial Resistance Center. Her clinical research interests include understanding how stewardship interventions and diagnostic innovations can reduce inappropriate antibiotic use in different contexts, including low-resource settings. And she is here with us to cover a very important topic, implementation versus innovation. Dr. Semret?
Thank you. I don't see myself. Oh, there they are. Okay. So I'll start with my disclosures. My research funding is all public, but relevant to this talk, I have received in-kind support from the company Diasorin, which is a manufacturer of a new diagnostic test, which I'll be talking about very briefly. In the past, I've also received in-kind support from both Biomérieux and First Line. They were here earlier today for a clinical research project that we conducted in Ethiopia. That was a cohort study on hospital-associated infections and stewardship interventions in low-resource settings. Finally, I need to say that the network that I work in and for which I lead stewardship, so the MUHC, is a subscriber of a product that's been alluded to earlier today. So LUMED, which was started in Sherbrooke University and has been acquired by Biomérieux, is a tool that we use in our stewardship practice. So these are my relevant disclosures. So a lot has been said today, so I hope that I'll be complementary and not completely redundant. One of the main points I'd like to make is that although it's been said that stewardship in hospitals is quite well established, especially in Canadian hospitals, there's still a lot of challenges still in implementation. Even when it's implemented, there are newer and newer building blocks to add, and innovation is not implementation versus innovation. It has to be, it's innovation and implementation. And so this is not a scientific talk, I'm just going to be sharing our experience and describe to you how we do things at the MUHC, and hopefully you'll see a way of maybe integrating these two conceptually different approaches. So our aim, obviously, and this is an aim that's been shared by everybody here, is to decrease the percentage of antibiotics that are considered inappropriate, so misuse, or excessive. And so stewardship programs are usually organized around a set of activities that, as has been said earlier today. And it is an accreditation requirement. So almost all acute care hospitals in Canada now have a stewardship program, at least on paper. But successful programs know that they can reduce total use of antibiotics by somewhere between 15 to 30%, depending on the situation, in the first few years. And if you maintain your stewardship program, then you plateau, okay? You don't continue to decrease, but if you stop your stewardship program, you go right back up. And this has been shown over and over again. So we know that in hospitals, there's been a lot of progress in Canada, and stewardship programs have led to overall decrease in antimicrobial use in many of the Canadian healthcare systems. But the issue is that inappropriate use, and so there's a range of estimates. Some people say 20%. In our institution, it's probably closer to 30% of antibiotics are still considered inappropriate. And of greater concern is the rising use of drugs classified in the reserve category. So a 52% increase in reserve drugs. Although our usage is still quite low, the rates are increasing. So to illustrate these things, I'm just going to share with you a vignette that I'm sure the clinicians in the room will be very familiar with. So this is just pulled out from our records, our audit records from very recently. So typical case, a 72-year-old man, COPDer, who's on oxygen at home, chronic steroids, gets frequent exacerbations for which he gets admitted to hospital, and he's treated as a pneumonia. And the sputum cultures, he's been colonized with Pseudomonas. So, and he's been treated with many different antibiotics over the course of many years. So his DOT, so days of treatment per year, is 100. So 30% of the year he's on antibiotics. And so his isolate in 2011 shows that it's a pan-sensitive isolate. And then you see the emergence of resistance to Cipro, increasing resistance, and most recently now pan-resistant Pseudomonas isolate, which as per our hospital laboratories protocol, this is an isolate that would require expanded testing. So he's now on one of the newer reserve agents. So how do you assess a case like this, and how do you decide whether the treatment is appropriate or not appropriate? So this is one of the common challenges that we're beginning to encounter. Now go across the world, different kind of vignette, and I'm not talking about stewardship efforts in low resource settings, but it's just to illustrate a different kind of reality, hospital reality. So a 3-month-old baby. This is in Ethiopia, which is where one of our sites was, born with congenital abnormalities and was admitted for elective neurosurgical procedure. As is the practice over there, he's put on antibiotics prophylactically right before the surgery and for a few days after. And on day 7, he becomes febrile, lethargic, vomiting. There's a diagnosis of meningitis made based on a lumbar puncture and a CSF culture. The CSF culture grows Acinetobacter, pan-resistant, including to the antibiotics that are not ever or very rarely used in that particular hospital, and certainly that the baby never got. So what does this mean? So this is not a real stewardship issue. Obviously, this is an infection control issue. So the paradigm that we need to always keep in mind as we're talking about stewardship building blocks and implementation is that the trajectory for patients coming into our healthcare system, whether it's here or in a low resource setting, is that they generally come to us unexposed with a diverse microbiome illustrated by the different colored dots into their abdomen. And once they're in hospital, they might acquire a drug-resistant organism represented with that little red star. If they receive antibiotics, there's a selection process, and they get dominated by the multi-drug resistant organism, and depending on specific host factors, they may or may not develop severe illness. So infection control is the very first building block of any effective stewardship program, and stewardship is obviously really around preventing the step from colonization to domination. So I won't go back through a lot of this that has been discussed today, and there's a lot written about the core elements and checklists required for effective antimicrobial stewardship programs. But I do want to say that the select actions, which the previous panelists were talking about, once you've decided on your structures and your processes, the actions that you decide, this is really not only key, but it's not as easy as saying we're going to do prospective audit and feedback. It's the who does it, when do you do it, how frequently do you do it, where do you do it, and how do you do it. So this is really a very involved process that needs to be revisited over and over and over again. And once you've as well, there's the monitoring, the expansion, and at what point do you integrate new tools into your system? So these are this staircase, which looks simple on paper, really requires an approach of continuous revisiting and continuous optimization. So somebody mentioned the implementation gap earlier today. So yes, hospitals, even in Canada, tertiary care hospitals, academic centers, we all have programs, but our programs vary widely in scope and in maturity. But I think we share challenges. Not only do we have limited dedicated personnel, but our clinical priorities may shift. So how do I convince my bosses or the pharmacy chair that a stewardship pharmacist is more important than a geriatric pharmacist who's doing polypharmacy, deprescribing for the elderly, and preventing immediate falls? right? So there's a lot of competing clinical priorities. People talked about the emergency room, the ICU, etc. We've also talked about fragmented data, lack of IT integration, accountability, etc. Excuse me. So implementation of effective antimicrobial stewardship is very slow, it's very context dependent, and it's extremely resource intensive. Meanwhile, there's the whole promise, obviously, of getting new tools, emerging tools, so digital solutions, rapid diagnostics, and biomarkers. So my take on all of this is that you really have to think ahead of all these tools and figure out how you're going to integrate them before you integrate them, and really have a plan for measuring their impact before you've integrated them. So one of the things that we did is, as we started our version 2, there was a version 1 of our stewardship program before I joined the group, before I became the lead. So we took about 6 months, and one of my early stewardship pharmacists is here in the room, Kian Lee, who's now moved to Toronto, unfortunately. But we spent about 6 months planning every single step, conducting little pilots on different wards, deciding which wards were going to be our targets, and obviously central to our program was going to be audit and feedback, because there's no way you can do effective stewardship without having a prospective audit and feedback interventions. So we decided that an electronic dashboard, so the LUMED tool that I referred to earlier, was going to be actually a big part of what we were going to do. So that was an early adoption. We were one of the first customers of the company. And the advantage of this software was that the first thing was it was going to help us identify cases. So we use it for case finding, okay? Rather than printing lists of who's on an antibiotic in our hospital today, first thing in the morning, and then running around the wards trying to match that list with medical records or talking to people, we needed to have an easy way of finding cases. And that case finding can be by target antibiotics, it can be by alerts, it can be by wards, it can be by patient type. So we decided on what is the metric, what is the first filter and what's the second filter. So that was a big first step. The second thing that it helps us to do is to basically do the first step of stewardship, which is the easy quality assessment. So the easy quality indicators are things like spectrum, when you already have a microbiology results, the dose, obviously, the duration, if the indication is very clear, and drug-drug interactions. So there's really the easy quality indicators that should be done very quickly, and we do this again with this dashboard, with this electronic tool called LUMED. The final step of the audit and feedback is the hardest. So advanced reviews, so really deciding whether a prescription is indicated or not indicated, requires a lot more than what the electronic support system can offer us today. This really usually requires a case narrative, so a review of the chart, understanding the chart, and being able to really infer based on a lot of the information. So it depends actually on the quality of the documentation, not only by the clinician who's writing the progress notes, but also the pharmacist interpreting, or the physician interpreting that information to infer the indication, keeping in mind that today, in 2025, patients that make it to a hospital and are admitted don't have a straightforward diagnosis. Nobody comes in with just a simple pneumonia. You have 20%, 30% of them have a diagnosis of sepsis. Are you going to take a chance with a diagnosis of sepsis, or are you really going to try to understand how much of this is CHF with a little bit of fever that's unrelated, how much of this is cardiac versus pulmonary, et cetera, et cetera. So the credibility part of this process is essential, and this is where most of our misuse comes from now. Once you've done the easy stuff, which is where most of us Canadian hospitals are at now, it's to figure out how do we tackle the 20-30% of antibiotic prescriptions, particularly the watch and the reserve categories, which are our main targets, how do we get to those? So prospective audits, we don't actually have a very good way of rating the quality of prescriptions. As some of you have alluded, we don't actually have a universally acceptable definition for what's a high quality prescription, what's a medium quality or a low quality prescription. We have sort of the 4 moments of antibiotic prescribing. We can easily say, diagnosis, choice spectrum, dose, and duration. But the diagnosis part, as I mentioned, is a very difficult one. But as we've been doing audits on various units and on various parts of the hospital, we start seeing some patterns emerge, all right? So you know that in some cases, it's defensive practices. For example, a surgeon has opened a belly, is worried that there might have been a little nick during the surgery and that there might have been a bowel perforation, and he doesn't want that patient, obviously, to develop an intra-abdominal collection. So there will be a prolonged post-operative prophylaxis, and it may be justified because he knows what happened during the surgery, or it may not be justified. But this is, it's sort of, you begin to get a sense of how people prescribe and why. So you have to start with giving them the benefit of the doubt, obviously. In some other cases, it's misconceptions. So I won't call them diagnostic errors, but it can be the misconception. So in our hospital, we haven't had too many problems with treating asymptomatic bacteria for quite some time now. I think most of our clinicians are at the stage where they understand not to treat asymptomatic bacteria, but you'll still have, the little old lady who comes in confused and delirious. Is she asymptomatic? She's not asymptomatic. She has symptoms, and she has bacteria. How do you tackle that? It's, would be easy for me to come and say, no, this is asymptomatic bacteria, but we have to start assessing these kinds of scenarios. The other frequent misconception is the diagnosis of urosepsis. So you kind of have to explain to people, for sepsis, you need to have this and this and this criteria. So this is a UTI, but not a urosepsis. So those, and then of course there's cognitive biases, sort of a misjudgment of the potential for adverse events happening because of antibiotics, for example. So we started using all of these patterns that were emerging to really inform our guidelines. So our guidelines are not just about how to manage empiric diagnoses. There's a front page. So we precede the management part with 1 page of addressing these common misconceptions and really focusing on defining syndromes, defining common pitfalls, describing what is, in our institution, the cumulative antibiogram for E. coli is X or Y. So we have a front page, and then a second page is just the management outcomes. So our audits inform not only the immediate feedback, but they inform our guidelines and our research interventions, as well as monitoring. So defining prescription quality, as I mentioned, and I see somebody has been nodding in the back over there, it's really variable between centers, definitely, and also between experts. So it's easy to agree on a few things, especially PK/PD considerations. It's much more challenging once you get to a certain level of complexity to agree on when an antibiotic is indicated, somewhat indicated, or not indicated. And even within experts, so in our center, we're all kind of trained very similarly. We work together, we've worked together for many years, we have rounds, etc. We still don't agree on certain things. There's a lot of the variability stems from our interpretation of a documentation. So there's a lot of documentation issues, but there's the way I might understand somebody's progress notes versus my colleague, in addition to, of course, personality issues and things that have shaped my practice. So This, in my opinion, is one of the big research gaps. It's not particularly sexy or innovative, but it's an area that I think has to be the focus of the next few years in stewardship research, is to define prescription quality, to define how do you even validate a rating scheme, a prescription rating scheme. Do you just do an inter-rater variability? Can you connect it to clinical outcomes that matter? What are the clinical outcomes that matter? So this is a big research gap that we have not yet addressed. So data monitoring or facilitating monitoring, we do use a module within that same software that I mentioned, and it allows us to very easily monitor antimicrobial use in our institution. So just a short button, and we can see over time reduction in use of antimicrobial, reduction in consumption of antimicrobials in the institutions where we have prospective editing feedback. There is one site in our network where we have access to the electronic data, electronic dashboards, but no team conducting audit and feedback prospectively. And you see that's the site that has seen an increase in their antimicrobial use over time, including the use of meropenem. So we show this to our leaders to say, lack of resources, no pharmacist on site with an ID physician doing prospective audit and feedback, but you have all the electronic tools just the same as everywhere else. This is what happens. We also use the same tool to generate our cumulative antibiograms and can show that, for example, E. coli antibiogram, the colors have stayed the same. For most antibiotics, it's still green, so we have relatively susceptible isolates. We're maintaining a low rate of resistance. And if I showed you the antibiogram for the ICU, where we have very few activities so far, that's where the resistance rates are much higher. So cumulatively, of course, you see the benefit, as many other hospitals have shown, a decrease in antimicrobial use overall, an increase in the prescription quality as the way we define it and the way we measure it, so as well as an increase in adherence to the recommendations. So acceptance of recommendations is also increasing, and we have different units which are going to be the target of enhanced work. So landscape of innovation. So we talked about more novel diagnostic tests. So this has been mentioned, the importance of diagnostic stewardship, because even nowadays, when we're doing audits, most of our alerts generated by our electronic dashboard have to do with a potential for undertreatment. So we get a flag saying this patient may be undertreated because there is a finding of a swab result where there is growth of an MDR in a patient who is on a first-line antibiotic. Most of the time, those are false alarms in the sense that there's a lot of patients being tested unnecessarily with cultures from open wounds. Somebody had mentioned endotracheal secretion, sputum samples, etc. So if you did not have the ability to go and actually check the chart or go at the bedside, you would be reacting to these kinds of results. This is what clinical decision support tools could be leading you towards. So this is a big warning signal to say electronic and faster is certainly not better. In the old days, back in 2009, we had implemented a multiplex respiratory virus PCR assay, 2009 being the year of the H1N1 pandemic, if anybody's old enough to remember that. And we were pretty certain that it was going to change prescription behavior at the time, that people were going to see the RSV and the other viruses in hospitalized patients, and that would somehow, that cognitive additional knowledge would lead them to reduce their inappropriate antibiotic prescribing. And we've unfortunately been able to show very compellingly that it did nothing to change antimicrobial prescriptions. On the contrary, our clinicians started demanding more antivirals. They wanted antivirals for adenovirus, for HMPV, etc. So it increased our use of oseltamivir, the agent against influenza A, but it did not reduce the use of antibiotics at all. So just a warning sign that more diagnostic tests may not lead to changes in prescriptions. Another example here is procalcitonin, so biomarkers. There's the promise that biomarkers are going to help us rule out bacterial infections and potentially stop antibiotics earlier or sooner. We've seen through numerous studies that adopting these sort of biomarker tests without a treatment protocol leads to no beneficial impact. And then there was this recent study done or not so recent, but this very well-designed study conducted in multiple centers in the US, I think it was 14 centers, with a very good protocol and a randomized controlled trial. That even in that study, they showed that there was very little difference in antimicrobial use between the intervention group and the control group. So does that mean procalcitonin is a terrible biomarker, or does it mean that everything is context specific and that the value you should expect from these is probably marginal when it's applied alone? You need probably bundle approaches, just like they've done in infection control. You're going to need a bundled approach for a lot of these interventions. So the final thing that I'm going to propose, or the final kind of innovation, is biomarker signatures. One such example is a novel diagnostic test. The test is called MEMED-BV. It's made by the company or it's sold by the company Diasorin right now. This is a test that is the result of it combines 3 different biomarkers which are integrated into a signature. So the test gives you a score, so it's an interesting idea. A score that, if it's elevated, it's a high sensitivity and specificity or not specificity, but high sensitivity for bacterial infection. And if the score is low, it has a very good negative predictive value for bacterial infections. So it's been already validated or tested across several units, the emergency department, outpatients, as well as general medical wards. But it hasn't been tested in sort of highly complex hospitalized patients. So this became an opportunity which we decided to embed in a clinical trial. And we actually chose the ICU. ICU because this is where currently most of the prescriptions in Canadian hospitals, the highest volume of prescriptions is right now in the ICU. The prevalence of antimicrobial use in most ICUs is up to 60%, maybe even higher. In our institution, it's around 67%. And it's also the unit which uses the highest proportion of reserve drugs, as you can imagine. And so this is an area where it's not easy to walk in and say, I'm going to do prospective audit and feedback, because you'd be there the whole day. We just don't have the resources to spend 5 days a week in the ICU, where the cases, not only is the volume of antibiotics very high, but the complexity of the cases is such that you might as well do a full-blown infectious disease consult as opposed to thinking you can resolve that with just a pharmacist in 15 minutes. There is a lot of diagnostic uncertainty. Most of the patients are undifferentiated when they're there, they're unstable. So, it's kind of appropriate for a critical care or an intensivist to initiate rapid antibiotics. So we're more trying to decide, can we stop them from escalating from pip/tazo to mero/vanco as soon as the patient's blood pressure starts oscillating? This is kind of where we're at with patients. And so it's become quite impossible to decelerate or to step down in the ICU. So we thought this is the best place to look to do a test on a biomarker. But we didn't want to do a test validation, or our purpose is not diagnostic test validation. We want to see whether it's going to work in real life. So we have designed a trial called the BAST ICU trial, which tries to answer the question of, can a biomarker signature supported treatment decision matrix have a beneficial impact on, and on patient outcomes in an ICU? So we're trying to achieve a reduction in antibiotic use without compromising patient safety, and we're using that opportunity to actually quantify all of the adverse events that may be developing on patients in the ICU. And we try to embed the score results. So we have an intervention group and a control group where we've designed a decision matrix that's kind of protocolized. So my final slide is to say, I hope I've convinced you, but I think you've heard a lot about this all day, that antimicrobial stewardship is really incremental. And even if you have a well-established, well-run program, it's a program that has to continue being built upon. You have to get the basics right, of course, but then you have to also leverage innovation pretty early on and embed it in your processes. So as far as I'm concerned, the electronic tools, they exist, and they don't necessarily entail an overhaul of your entire electronic medical systems or LIS. Some of these are like patches, so they can just come in and connect to what you already have present. These are not only important facilitators, but they sustain the engagement of the team, the pharmacists. They facilitate benchmarking as well. And innovations are really most effective when they're integrated into, in my opinion, mature programs. So with continuous measurement and thoughtful stewardship of diagnostic tools and biomarkers. But the real innovation, as far as I'm concerned, is going to be improving the quality of stewardship studies. And there's a lot of ideas that are percolating. I hope to hear some of them later today, and hopefully we'll discuss them with questions as well. Thank you very much.